Hi guys, welcome to this tutorial on arterial blood gases. In this tutorial we're going to talk about arterial blood gases or ABGs, and we're going to teach you a super simple system you can use to quickly analyse blood gases. So if you're new to blood gases, or maybe you're working on a ward and people are talking about metabolic and respiratory acidosis and you don't really know what they're talking about, this video is for you. So let's dive in. So after you put your blood sample in the analyzer, you'll get a printout of the results that will look a bit like this. Now if you're new to ABGs, this might seem daunting as there's over 20 results on the printout, but don't despair. The blood gases are actually just these top 5 results, and this is what we're going to teach you about in this video. The reason the other results are there is that someone in the past probably thought it would be helpful that if you are testing a blood sample, you could add glucose and electrolytes and run it through a co-oximeter. So you get a lot of helpful information, but these aren't blood gas results. Okay, so we have our blood gas results, but where do we start? Now most people tend to be drawn to the oxygen reading first, but I would suggest leaving that to the end. The reason for this is whilst oxygenation is important, you can get a reasonable idea of oxygenation from a pulse oximeter. It's not usually the main reason for doing a blood gas. Usually the blood gas is done to establish what's going on with the patient's acid-base balance. So that's where we're going to start. Step 1. So the first thing you want to check is the pH. With just the pH alone we can tell if the patient has a normal pH or if their blood is too acidic or too alkali. Now you may remember from chemistry lessons in school that a neutral pH is 7. Now the human body is a little bit different in that the normal pH in the human body is 7.35 to 7.45. So if your pH is between 7.35 and 7.45, you have a normal pH. If you have a patient who has a pH below 7.35, then the patient's blood is too acidic and the patient is said to have acidosis. If the pH is above 7.45, then the patient's blood is too alkali and they're said to have an alkalosis. So with one result, you can now tell if a patient is acidotic or alkalotic. Now we know whether the patient has an alkalosis or acidosis, the next thing to do is to have a look at the respiratory and metabolic systems. And this moves us on to step 2, where we look at the carbon dioxide level, and this is shown by the PCO2. The partial pressure of CO2, or PCO2, is what we use to assess the respiratory system, as it's the job of the lungs to expel carbon dioxide when we breathe. Now you may be wondering what effect carbon dioxide has on pH. Well, carbon dioxide dissolves in blood and forms carbonic acid, so increasing the amount of CO2 in your blood makes the blood more acidic. Conversely, if you lose or expel too much CO2, carbonic acid is broken down and the blood becomes more alkali. An example of a situation where the carbon dioxide builds up might be the patient who has taken an opioid overdose, and that depresses the respiratory system and causes them to take very slow breaths, and this allows carbon dioxide to build up and cause an acidosis. An example of the reverse situation where the CO2 is too low would be the patient who's hyperventilating during a panic attack, and that fast breathing blows off CO2 and makes the blood too alkali. And it's the alkalosis in this situation which explains why hyperventilating patients get tingling around the lips and fingers, as that change in pH affects calcium binding. Now, the normal range for CO2 is 4.5 to 6 kilopascals, or if you're working in millimeters of mercury, 35 to 45. If the PCO2 is greater than 6 kilopascals or 45 millimeters of mercury, the respiratory system is causing acidosis. If the PCO2 is below 4.5 kilopascals or below 35 millimeters of mercury, the respiratory system is causing alkalosis. And that's the respiratory system. The next step is to look at the metabolic system. And the metabolic system can be assessed using one of two measures, either the base excess or the bicarbonate. And these two things essentially tell you the same thing. And that's because bicarb is the main base in the blood. So if bicarb or bicarbonate goes up, base excess will go up. And bicarbonate is a base, and a dissolved base is called an alkali. So high bicarb causes alkalosis. Now, the normal bicarb level is 22 to 29 millimoles or milliequivalents per litre. And if your bicarb level is higher than this, above 29, it means the metabolic system is causing alkalosis. If the bicarb is low and you have a bicarbonate level below 22, it means the metabolic system is causing acidosis. Base excess, as the name suggests, is a measure of how much extra base there is in the blood compared to normal. And base excess will typically mirror the bicarb, as bicarbonate is the main base in the blood. But some would say base excess is maybe a more comprehensive measure, as well as bicarb, it includes some other minor bases that contribute to the metabolic status of the patient. Now, one important thing to grasp when you're thinking about base excess and the results and the way it's scaled is that we're measuring excess base, not total levels of base. And this means that we're looking how much base we have on top or below normal. And a healthy individual shouldn't have deficient or excessive amounts of base in the blood. So normal base excess is near zero. Now, we do allow for some variation between individuals. So the normal range is -2 to +2. So if you have extra base in your blood, such as if you have a high bicarbonate, the base excess will rise. And if you have base excess greater than +2, this tells you the patient's metabolic system is causing alkalosis. If you have lower than normal amounts of base in the blood, then the base excess will reduce and actually becomes negative. And a negative base excess, which is also known as base deficit, as in a base excess that is below -2, tells you the patient's metabolic system is trying to cause acidosis. And that's all you need to work out a patient's acid-base status. The last thing is to put it all together, and that's pretty logical. So let's look at some examples. If you have an acidotic patient, which you'll know because looking at the pH it's below 7.35, you want to know whether it's a respiratory acidosis, a metabolic acidosis, or a mixed acidosis. A mixed acidosis means that the respiratory and metabolic systems are trying to cause acidosis. So a PCO2 is high and the bicarb and base excess are low. A respiratory acidosis means the respiratory system is causing the acidosis. So you have a high CO2, but the bicarb will be normal or possibly raised. A metabolic acidosis means the metabolic system is causing the acidosis. So the bicarb and base excess are low, whilst the PCO2 will be normal or low. And that brings us on to the topic of compensation. Now, the pH of human blood is tightly controlled, and it needs to be because our enzymes function properly at a narrow pH range of 7.35 to 7.45. Our bodies have homeostatic mechanisms to try and keep our pH and other biological parameters in a steady state. Our respiratory and metabolic systems will usually try to compensate for the other if one of the systems is causing the pH to go out of range. So, for example, if the metabolic system is causing acidosis, we might start to breathe faster as our respiratory system tries to reduce our carbon dioxide and make the blood less acidic. And this process is called compensation, and it can work in either direction. So here we have an example of a blood gas which shows this. Looking at the pH, it's low, below 7.35. The patient has an acidosis. If you look at the CO2, it's low, which should cause an alkalosis or a high pH. Then we look at the base excess and the bicarbonate, and these are both low. So you can see the metabolic system is causing acidosis. Clearly in this case, the metabolic system is winning, if you like, or is said to be dominant, and the acidosis is metabolic in nature, with the respiratory system trying to compensate. And that's blood gases pretty much in a nutshell, or at least that's a blood gas acid-base balance. So to summarise, when you're looking at blood gases, check the pH, and then you know if the patient has an acidosis or alkalosis. Step 2, check the respiratory system by checking the PCO2 and work out, is the respiratory system trying to cause acidosis or alkalosis? And that's based purely on whether the CO2 is low or high. Step 3, check the metabolic system. You can use either base excess or bicarbonate or both. And again, work out if the metabolic system is trying to cause acidosis or alkalosis. You then need to see which system is dominant. Usually one system will be dominant with the other one trying to compensate. Sometimes both the systems will be trying to push in the same direction and will be contributing to the same derangement, in which case the patient's said to have a mixed acidosis or a mixed alkalosis, depending on which way they're going. If one system is dominating and one system is trying to cause acidosis, the other will usually try to compensate and cause alkalosis or vice versa. And the derangement is named after the dominant system. So for example, if you have a patient with a pH below 7.35 and they have they're acidotic and the metabolic system is trying to cause acidosis and they have a low bicarbonate or a negative base excess, the patient is said to have a metabolic acidosis. And that's it for blood gases and acid-base status. Now, I haven't mentioned oxygen yet, as oxygen doesn't really contribute to acid-base status, but we should probably talk about it just to complete things. Now, the PO2 lets us know how well oxygenated or hypoxic a patient is. The normal range is 10 to 13 kilopascals or 75 to 100 millimeters of mercury. So if the PO2 is below 10 kilopascals or 75 millimeters of mercury, the patient has low blood oxygen, which is called hypoxia. And this leads us on to some other terms that you might hear when you're dealing with blood gases. And these terms are type 1 and type 2 respiratory failure. And these are really quite simple. In type 1 respiratory failure, this means the patient has a low PO2, but the PCO2 is normal or even low. Or another way to put that is the patient is hypoxic, as in they have a low PO2, but they're not hypercapnic. And hypercapnia means a high carbon dioxide or PCO2. Type 2 respiratory failure, on the other hand, means the patient has hypoxia, like type 1 respiratory failure, but they also have a high PCO2, so they are retaining too much carbon dioxide. And another way to put this is the patient is hypoxic and hypercapnic. And that wraps up this video on ABGs. I hope it gives you a clearer picture of blood gases. If you have any comments or suggestions for future videos, please let us know, and if you like the video, please subscribe to our channel.